Hello everyone. In this video, I'm going to discuss the basics of megaloblastic anemia. So what is the reason behind megaloblastic anemia? The reason is defective DNA synthesis. So this is the mechanism behind development of megaloblastic anemia. But the most common cause for megaloblastic anemia is B12 and folic acid deficiencies. As you all know, it is vitamin B12 and folic acid deficiency that will cause megaloblastic anemia. How exactly deficiency of these two vitamins can cause defective DNA synthesis, that we'll discuss later. But first, we'll discuss what is going to happen whenever there is a defective DNA synthesis. Before understanding the megaloblasts, first of all, we need to understand the normal erythropoiesis. Okay, normal erythropoiesis. This we have already discussed in detail in previous videos. Now I'll just tell briefly so that you can understand the development of megaloblast. So normally what happens? So everything starts from the hematopoietic stem cells. As we all know, it is hematopoietic stem cells that will give rise to colony forming unit for erythropoiesis, and this colony forming unit erythropoiesis that will give rise to the first cell in the series of erythropoiesis, that is pro-erythroblast. Of course, it needs stimulation from erythropoietin, which is released from the kidney. Okay, so the first cell is pro-erythroblast. Okay, and we have already discussed that pro-erythroblast, then it will become basophilic erythroblast, then polychromatophilic erythroblast, then orthochromatic erythroblast, then the reticulocyte. As you can see, as the cell is getting mature, the size of the nucleus is getting shortened. Okay, so size is becoming smaller and smaller, and ultimately it is coming out of the cell because the mature RBC doesn't need the nucleus. Okay, so if you look at the pro-erythroblast, it is the largest cell, and it also has a large nucleus with open chromatin. Why the chromatin is open? Because in its open state, it can be transcribed easily to mRNA, and there will be a process of translation leading to protein synthesis. Which protein they want to synthesize? They want to synthesize hemoglobin. Okay, so erythroblasts, they want to synthesize hemoglobin. That is why the chromatin is active. Okay, so this active chromatin will take up this open configuration. Okay, and you can see the cytoplasm is slightly blue. That is because of the mRNAs. Okay, the next one is the basophilic erythroblast. Basophilic means here the cytoplasm is blue. Cytoplasm is more blue. That is why the name basophilic, that is blue because of more and more mRNA, which are destined for synthesizing the hemoglobin. Okay, the next step is polychromatophilic erythroblast. Here you can actually appreciate the hemoglobins in the cytoplasm. That is why the cytoplasm will take both red color and blue color. Basophilic, it is because of the mRNA, and eosinophilic because of the hemoglobins. Okay, that is why the name polychromatophilic erythroblast. Then the orthochromatic erythroblast, where the hemoglobins will be predominant in the cytoplasm. So that is why it will become red or eosinophilic, and ultimately the reticulocytes. The reticulocytes will be completely eosinophilic, but only few dots or net-like chromatin structures you can find in reticulocytes. And ultimately, it will go to the peripheral blood, and it will become the mature RBC. It will become the mature RBC. So this is what normally happens, and you can appreciate that the size of the nucleus is gradually shortening, and also it is becoming more and more condensed. Okay, so the maturation of nucleus happens in this way. So maturation of nucleus happens the size will gradually reduce, and the chromatin inside it will become more and more condensed, and ultimately it will become pycnotic, and it will come out of the cell. So this is what normally happens. But we'll see what is going to happen in patients with megaloblastic anemia. So whenever there is defective DNA synthesis, the cytoplasmic maturation is not affected. Okay, cytoplasmic maturation means the production of the hemoglobins. Okay, so hemoglobin production, I mean the transcription from DNA to mRNA and translation from mRNA to protein synthesis, that part is not affected. That means the cytoplasmic hemoglobin accumulation, that part is not affected, but the nuclear maturation cannot happen properly. Okay, so that is why there is nuclear cytoplasmic asynchrony. Okay, so cytoplasm is matured, but the nucleus is not matured. That is why the cell, even if the late erythroid cells, they will have ample amount of hemoglobin because the chromatins are still producing more and more hemoglobin, and also the nucleus is not becoming condensed. It is not getting condensed. So even in this late erythroblast phase, you can appreciate that the size of the erythroblast is still high. I mean, still it is a larger cell, and also it has a open chromatin. It has a nucleus with open chromatin. So this is known as a megaloblast. This is actually a megaloblast. Okay, so megaloblast, it will have a larger size compared to its corresponding normal cell. It will have a larger size, and it will have a nucleus with open chromatin. Now this open chromatin, you can see if you can see here, this is the bone marrow picture. You can see these are the late erythroblast cells. As you can appreciate, the cytoplasm is eosinophilic. Cytoplasm is eosinophilic. That means the cytoplasm is already matured. If you compare with the pro-erythroblast, so this you can tell it's a pro-erythroblast because here the cytoplasm is blue. That means cytoplasm is not yet matured. Okay, but if you can see this cell already the cytoplasm is matured. That is why the cytoplasm is eosinophilic. But the nucleus, this cell should not contain this kind of nucleus. The nucleus is still very large and it also has the open chromatin. It is sometimes described as sheave-like chromatin. Sheave-like chromatin. Okay, so this is actually megaloblast. This happens because of defective DNA synthesis leading to nuclear cytoplasmic asynchrony. Basically, delay in the maturation of the nucleus. Okay. Now we'll see what are the consequences of this kind of development. Okay. So what will be the consequence? Now, our bone marrow will think that this cell is abnormal. Late erythroblast cell should not contain this type of nucleus. Now, bone marrow will realize that this cell is somewhat abnormal. So it will cause damage to this precursor cell. Okay, so there will be, that is known as ineffective erythropoiesis. We have discussed previously, if the RBCs are getting destroyed outside the bone marrow, that is in the peripheral blood, that is known as hemolysis. But if the developing RBCs or developing erythroids are getting destroyed inside the bone marrow, that is known as ineffective erythropoiesis. Okay, so it will cause ineffective erythropoiesis. Now this ineffective erythropoiesis will stimulate further erythropoiesis. Okay, so it will stimulate further erythropoiesis as a compensatory mechanism. Okay, so there will be increase in erythropoiesis because of this ineffective erythropoiesis. This is what we have already discussed when we discussed about the thalassemia. In thalassemia also there is ineffective erythropoiesis, which is ultimately causing increase in erythropoiesis. So this will cause increase in erythropoiesis. So that will cause erythroid hyperplasia. So if you see in the bone marrow, you will find erythroid hyperplasia. Erythroid hyperplasia. Normally in the bone marrow, the myeloid to erythroid ratio is 3:1. It is normally 3:1. But in patients with this megaloblastic anemia, there is increase in the erythroid component, so this ratio will be altered. Okay, so this ratio will be altered. Normally it is 3:1. Okay, so we are going to get erythroid hyperplasia and you are going to get this megaloblasts. Megaloblast, this will have the sheave-like chromatin, open chromatin. Okay. Now, other thing is, if this megaloblast will give rise to, it will mature enough to give rise to RBCs. Now, these RBCs definitely they'll be of larger size. Okay, they will be of larger size definitely, and also they will have ample amount of hemoglobin. As I told you, the hemoglobin production will continue till the late erythroblast phase. So they will have ample amount of hemoglobin. So the size will increase. That means the MCV will be increased, of course, and also the hemoglobin content, the mean cell hemoglobin will also increase. However, because both are increasing, the MCHC will not be affected. The hemoglobin concentration will not be affected because both the volume and the hemoglobin content is increasing. Okay, so this larger cell is known as the macrocyte, and if the hemoglobin content is increased, that is known as the hyperchromasia. Okay, so many times we will find in the peripheral blood we are going to get this macrocytes, or sometimes they will become oval shaped. So those are known as ovalocytes. So it is described as macro-ovalocytes. If you compare with a normal RBC, this you can tell a normal RBC. You can see here. If you compare that with this RBCs like this is again a large RBC. This is also a larger RBC. This is also a larger RBC. So these are all macro-ovalocytes. And also you can appreciate that there is the hemoglobin content is increased. That is why you cannot appreciate the central pallor. Okay, so many times you will not be able to appreciate central pallor in macro-ovalocytes. Okay, so you are going to get macro-ovalocytes, and also you are going to get hyperchromasia. That means the central pallor will not be seen. Central pallor is absent. Not in all cases, but many of these RBCs, many of these macro-ovalocytes, you are going to get this kind of hyperchromasia with loss of central pallor. And also sometimes this kind of cell can come into the peripheral blood, because the nucleus is not getting matured. Sometimes nucleus will still persist in the mature RBC. So sometimes you can get a nucleated RBC in the peripheral blood. So you can get a nucleated RBC in the peripheral blood also. Okay. So in this peripheral square, I have not shown a nucleated RBC, but sometimes you can find that. Okay. Apart from that, what else you are going to get? Now, this defective DNA synthesis, it will not only affect the process of erythropoiesis, it will also affect other lineage cells. So it is also going to affect the granulocyte lineage and also the megakaryocytic lineage. Because of involvement of this megakaryocytic lineage, you will find giant bizarre shaped megakaryocytes, giant bizarre megakaryocytes, and because of involvement of the granulocyte lineage, again the same thing will happen. There will be nuclear defect in the nuclear maturation, and in the granulocytic lineage, you are going to get giant metamyelocytes, giant metamyelocytes, and also band forms. Okay, so ultimately, actually, because of involvement of all the lineages, it will not only produce anemia, many times they will also produce pancytopenia, because they can involve all the three lineages. Okay, they can involve all the three lineages. That is why they can cause pancytopenia. Okay. What else? Because of this involvement of granulocyte lineage in the peripheral blood, what you are going to get? As you can see here, appreciate here. So this is actually a neutrophil, and this neutrophil you can tell as hyper segmented neutrophil. Hyper segmented neutrophil. Normally neutrophils would have 3 to 4 lobes. Okay, normally, I mean the nucleus of the neutrophil should have 3 to 4 lobes. But what happens in this condition, because of this defective nuclear maturation, they will have more number of lobes. Okay, so that is known as hypersegmented neutrophils, but this has a definition. To call it as a significant hypersegmented neutrophil, it has a definition. So that definition is either you should get at least one neutrophil with more than 5 lobes, one neutrophil with more than 5 lobes, or you should get 5% of neutrophils, 5% of neutrophils with 5 lobes, Okay, so this is the definition for hypersegmented neutrophil. I would say significant hypersegmented neutrophil. To call it as a significant hypersegmented neutrophil, at least you should get one neutrophil with more than 5 lobes, or you should get 5% of neutrophils with 5 lobes. Okay, in this condition, you can see 1, 2, 3, 4, 5, 6. So this is 6 lobes. So this is definitely a significant hypersegmented neutrophil. Okay, so these are the common peripheral smear finding that you are going to get in patients with megaloblastic anemia. Okay, there are some other findings also, slightly rarer compared to these findings that I'll tell here. So sometimes you will get this Howell-Jolly bodies. Howell-Jolly bodies. This also we have discussed when I taught you about the sickle cell disease. In sickle cell disease, I told you when the patient will undergo autosplenectomy, in those patients you are going to find this Howell-Jolly bodies. These are actually nothing but these are actually condensed chromatin materials. As I have told you previously, these reticulocytes, they have few net-like chromatin materials. Okay, they will have few net-like chromatin materials, and after coming to the peripheral circulation, the splenic macrophages will remove those chromatin materials, so that in the mature RBC you are not going to find any of those chromatin materials. But if the patient doesn't have a spleen, or the chromatin materials are significantly high, okay, so that is what happens in this megaloblastic anemia. The chromatin materials will be significantly high. That is why the splenic macrophages cannot completely remove all those materials. So you are going to find these Howell-Jolly bodies in patients with megaloblastic anemia. And that is and also we have discussed that in cases of splenectomy, in post-splenectomy cases, of course, splenic macrophages cannot remove those chromatin materials. So in those cases also, we are going to find this Howell-Jolly bodies. So Howell-Jolly bodies, these are also found in post-splenectomy cases. Post-splenectomy cases. Okay. The next one is Caboring. Now, as you can see, this is a ring inside the RBC. Inside the RBC. Sometimes it take up this figure of 8 appearance also. Here it is a complete ring-like structure. Sometimes they can take up this figure of 8 appearance also. This is more commonly asked in the exams. This is nothing but a mitotic spindle. Okay. All these things are happening because of this defective nuclear maturation. Okay. and excessive chromatin materials you are going to get going to find in the RBCs, and these abnormalities result from those defective nuclear maturation. How is the body caboting? And the third one is basophilic stippling. This you must have studied previously also. I have told you multiple times. Basophilic stippling. As you can see here, small blue dot-like structures. These are nothing but the mRNA, mRNAs over the mRNA, or you can say the ribosomes over the RBCs. Okay, this happens. We have also discussed that you are going to get this finding in pyrimidine 5' nucleotidase deficiency, lead poisoning, and also I told you that in patients with thalassemia, you are going to get this finding. Okay, so whenever there is ineffective erythropoiesis, all these RNA materials we are going to get over the RBCs, that is basophilic stippling. Okay, these are the 4 important examples: pyrimidine 5' nucleotidase deficiency, lead poisoning, and thalassemia, and megaloblastic anemia. These are the important examples for basophilic stippling. Okay, so these are all the points that you have to remember for megaloblastic anemia. Okay, Havel-Jolly bodies, Caboring, and basophilic stippling. And also I told basophilic stippling is found in pyrimidine 5' nucleotidase deficiency, lead poisoning, thalassemia. Lead poisoning, actually lead can actually inhibit this pyrimidine 5' nucleotidase. That is why in lead poisoning also you are going to get this basophilic stippling. Havel-Jolly bodies can also be found post-splenectomy and also after autosplenectomy in patients with sickle cell disease. And Caboring is nothing but mitotic spindle remnants. Okay, so these are all the findings that we are going to get in patients with megaloblastic anemia. There is one more point I'll try to mention here. Many times patients with B12 deficiency, there will be some kind of hemolysis, some kind of peripheral hemolysis that happens. Hemolysis in the peripheral blood that happens. Usually type of extravascular hemolysis. The exact mechanism behind this hemolysis we do not know, but some amount of hemolysis happens here. That is why many times you will find the features of hemolysis like increase in indirect bilirubin and increase in LDH. Okay, so these are the findings which usually you get in patients who are having extravascular hemolysis. So in patients with B12 deficiency also, sometimes you find this increase indirect bilirubin and LDH. Okay, not significantly elevated, but mild to moderately elevated. And also these patients will have this ineffective erythropoiesis, that means destruction of erythroids inside the bone marrow. These will also contribute to this increased bilirubin and LDH. Okay, so these are some of the findings. Sometimes vitamin B12 deficiency is confused with autoimmune hemolytic anemia because of this reason. Okay, so if you see the LFT report, if you see the LDH report, sometimes these are elevated in patients with megaloblastic anemia due to B12 deficiency also. Okay, so that is all about the basics. In the next lecture, we'll discuss about the B12 metabolism.